And good morning, good afternoon, good evening, everyone, and welcome to this last session of our IA 2030 WHO and TechNet 21 webinar series on why gender matters for immunization. Today, our presenters are going to discuss engagement with men and promotion of a family approach to transform gender norms. You can listen to this presentation in French, just like for the previous sessions. To do so, just click on the interpretation icon that you see at the bottom of your Zoom window and select French. I'm going to say that in French for our francophone colleagues. Pour écouter la présentation en français, cliquez sur l'icône interprétation qui est en bas de votre fenêtre Zoom et choisissez français. If you have any technical issue, please let me know in the chat and I'll do my best to help you with to solve that. And talking about the chat box, you can already introduce yourselves and tell us where you're from and your name. We'd be super happy to know who's with us today. During this presentation, you will probably have some questions, so don't hesitate to ask them at any time. Just use the Q&A box, which is also the icon available, another icon available at the bottom of your Zoom window, and ask your questions. Please don't hesitate, really, at any point. They're going to be addressed either in writing by our colleagues, by our presenters, or at the end of the session during the Q&A session. Finally, this session is recorded and we'll share with you the links to the video as well as the slides, probably tomorrow or the latest early next week. We hope you'll enjoy this session and I'll give the floor to Stephanie. Stephanie?
Thank you so much, Alex, and hello, everybody, and welcome to our 5th webinar in this webinar series on why gender matters for immunization. I hope that most of you have been able to join us for some of the prior sessions up until now, but just a quick recap for those who are new to today. So this is a webinar series that we've been running to feature the content from a joint guidance document from WHO, UNICEF, and Gavi that was published last year on why gender matters for immunization. And this guide covers the importance of considering gender when designing and implementing immunization programs, and links it to the Immunization Agenda 2030. As I said, this is the 5th webinar in this series. For any of you who have missed some of the prior webinars, all the materials and recordings are available on our TechNet landing page, and the link to that will be shared in the chat, as well as at the very end of this webinar. But the one thing that I do want to say is that, well, we've hoped that you've enjoyed this webinar series so far, and we are considering running a part 2 in the fall. And so we'd like to hear from you as to, what worked, what was most interesting to you about the topics that we've covered so far, and what additional topics you'd like us to feature in a subsequent webinar series. So after this, everyone that's registered will receive a short survey, and it would really be helpful to us if you could take a few minutes to fill it out. It's quick and anonymous. But really, we would love to hear some feedback on the series and any ideas for subsequent sessions. So please look out for that in your inbox following this webinar today. With that, we'll move ahead. So in the previous webinars, we've been doing a little bit of a deeper dive into some of the specific gender responsive approaches to immunization that we cover in the Why Gender Matters guide. And so today's topic, as Alex already mentioned, is going to deal with engaging men and families overall to transform gender norms and ultimately improve ownership over immunization status within the family and improve immunization coverage. So to discuss today, we have 3 different parts of the presentation and 4 different speakers in total to discuss this topic with you. We have Shirin Hidari, who's a senior gender advisor with us at WHO. We have Elizabeth Arladi-Parish, who is joining us from JPIGO. She's Principal Technical Advisor for Gender there. And then we have 2 speakers for our 3rd session. We have Alia Poonawala, who is the Senior Manager for Private Sector Engagement at the Gavi Alliance. And we also have Archana Chowdhury, who is the Senior Director for Senior Projects in the Group M Media India Group. So with that, I will hand this over to Shirin to take us through the first introductory session. Over to you, Shirin.
Great. Thank you so much, Stephanie. And delighted to be here. And I also saw some familiar faces among the participants. So looking forward to this webinar. So the outline of the session today is that we'll start with a quick recap of what it means to engage with men to transform gender norms, following with a presentation on men's engagement in child health and immunizations with a review of the evidence. And from there, getting some insights from provider to protector, rethinking the father's role in child health in India, an example from Safal Shuruaat program. And then hopefully we'll have time for question and answers. So before we will move on, I'm sorry, I think I went too quickly. It would be nice just to have a quick overview of the gender integration continuum. And this is a table that is adopted from WHO gender responsive assessment scale and provides an overview of each level with illustrated examples related to immunization programming. Programs and policies and interventions are considered to be gender responsive only when gender roles, norms, and inequalities have been analyzed and appropriately measures have appropriately addressed them to actively address the gender inequality issues. Gender responsive programs can either be gender specific, so that they target a specific group of women or men, or address specific gender related issues, but do not challenge gender norms and roles. Or they can also be gender transformative. And that means that programs are then trying to address the root causes of gender inequality and make an attempt to transform patriarchal and harmful gender norms and roles. Immunization interventions should, at the minimum, be gender specific and ideally, when often possible, be gender transformative. Gender unequal and gender blind programs can really be harmful, and as such, they are contrary to the IA 2030 core principles of do not do harm. Let me see if it goes to the next slide. Here we go. So targeting women only, while it might have the benefit of meeting or addressing the needs of women and girls, it misses out on the importance of involving men as co-parents and equally responsible for caregiving and joint decision makings about immunization. In many places, the health system does not adequately recognize fathers' roles in children's immunization, nor does it actively employ a gender transformative approach to immunization. And studies have shown that immunization programs that reach out to men have actually resulted in improved rate of immunization. So there are some benefits overall on the immunization program as well. Now, what can we do? What are the examples of approaches that can be taken to engage with men and promote a more family approach to transform gender norms? Most importantly, it's important to target both women and men as caregivers, as equally responsible in co-parenting and caregiving of a child, and as such, involving them in all immunization-related outreach and messaging. Important to also integrate themes such as gender equality, equal parenting, household decision-making, and men's equal share of childcare and other domestic responsibilities in all health promotion messaging, including home visits, and also including that in education curricula. Other examples is to train health professionals and health personnel to positively encourage men in prenatal consultations. We also have studies where the provider attitude can be a gender-related barrier to men's engagement and access to health services. And primary health clinics can really encourage men to take part in children's health and strengthen positive attitudes towards men who are more active co-parents and visiting health centers with their children. Engaging men's associations and groups, as well as traditional, cultural, and religious leaders on immunization-related communications can be very helpful, and also using male influencers to model gender equality behavior. So I stopped there, and please feel free to ask any questions, and I'm handing it over to our next speaker to present their very interesting presentation. Thank you so much.
Thank you very much, Sharon. Hello, everyone. My name is Elizabeth Arlotti Parrish. I'm a Principal Technical Advisor for Gender at JPIGO, and I'll be sharing with you the results of a recent evidence review that we conducted with support from Gavi on men's engagement in child health and immunization. Next. This evidence review was conducted, as mentioned, with support from Gavi and in collaboration with ministries of health and other stakeholders at the global level, and particularly in Pakistan and Togo. The project began relatively recently, this past February, and will be continuing until December 2024. And we'll be interacting at the global level, conducting evidence reviews, doing research such as this evidence review, and then we'll also be conducting operations research in the two countries. Next. So the first objective of this project was to explore the evidence around men's engagement in child health and immunization. There is a large body of evidence that shows us that men's engagement can improve health outcomes in reproductive health, maternal health, HIV, etc. However, the evidence base for child health and immunization is a bit less clear. So we devised this evidence review to look at these three main questions. The first question explores the current challenges and opportunities for engaging men in immunization and child health. The second is exploring effective and promising programs to engage men that can improve child health and immunization outcomes. And thirdly, we're looking at effective and promising gender transformative interventions that could be integrated into child health programs and services. And I just want to clarify the difference between questions number 2 and question number 3. As Sharon mentioned, programs can engage men in ways that are not necessarily gender transformative, that may be gender sensitive, gender specific, or, but hopefully not, may even cause harm, be gender blind. But we're looking at, we want to see how men's engagement interventions in general can improve child health outcomes, and then particularly how men's engagement interventions that are gender transformative can be integrated across child health programming. Next. The methodology was multi-pronged. We conducted a literature review with 20 peer-reviewed publications and an additional 8 studies from the gray literature that were recommended from our expert interviews. We conducted an online survey with respondents from Africa, Asia, Europe, Latin America, and North America. We also conducted key informant interviews with 15 global experts, as well as national experts in Togo and Pakistan. And finally, we wanted to ensure that people living closest to this issue of childhood immunization were not left out and that their voices are heard. So we also conducted focus group discussions in our 2 main countries of Togo and Pakistan with women caregivers, men caregivers, as well as immunization service providers. And here in the parentheses, you can see which questions are addressed by which process. So our focus group discussion primarily addressed the issue of challenges and opportunities. The survey and key informant interviews addressed all 3 questions. And the literature review primarily looked at the evidence with regard to men's engagement interventions and gender transformative interventions. Next. To guide this process, we used a few guiding frameworks. The first is the socio-ecological model, which you'll see shortly. And then we wanted to be very clear about what we meant by men's engagement. So we used the Interagency Gender Working Group's definition of men's engagement, which looks at men as clients themselves, as partners, and as agents of change in the global community. And often when we're looking at men's engagement interventions, it's that second category of men as partners that are most common. So we further delved into that category using Gal et al.'s global framework for assessing male involvement in maternal health, where you can see 5 different types of involvement for men as partners. And just to explain a bit too that are not quite obvious, we have the dimension of physical support, which is defined as men accompanying a woman to healthcare, or in the case of immunization, directly bringing their child to healthcare. And then practical support is a man providing other services that can support the woman to take the child to care. For example, providing transport money, helping around the house with household tasks so that the woman is free to take the child to care. Next. So let's get directly into the results. So first, we found challenges, many of which you may be familiar with. And I should note that we found across the 2 countries with our caregivers, as well as with our global experts and in the online survey, that challenges were very similar. Unless it's specifically noted here, the challenges were often mentioned by all 3 types of respondents. So at the political level, we found challenges related to a lack of health policies to include men's engagement specifically, as well as to support men's active role in caregiving. And this includes a lack of social and behavior change strategies that look explicitly at how to engage men using channels and messaging that resonates with them. At the health service level, we know that health services are often unwelcoming to men, operating hours often in conflict with men's work hours, and we see the secondary effect that because men are not engaged in the health system, it often limits their access to accurate information about immunization. All of our stakeholders were in agreement that one of the largest barriers to men's engagement are social and gender norms around the role of men and women as breadwinners and caregivers. And many of our experts noted that at the community level, many interventions that work to engage men did not address these norms and instead may reinforce negative stereotypes and power imbalances, such as the role of the head of household or men as primary decision maker within the household. We also see that at the interpersonal level, this dichotomy that while men do not play an active role in caregiving, they're the main decision makers for child health behaviors. And because of men's lack of information, their negative perceptions around vaccine, negative social influences, or influences from religious or other leaders, this can impact their beliefs around vaccine use. Our stakeholders in Togo particularly also mentioned the issue of family discord and how if a couple is experiencing conflict, the man may respond by refusing his wife permission to take their child to care. And they also noted in Togo that polygamy can be an issue, as if a man devotes resources and time to taking the child of one wife to care, he'll then be obligated to do the same with all of his other wives. And all of these challenges that we see at different levels, we also see at the individual level as men internalize this misinformation and socialization around their expected role in the family. Next. And here are a couple of examples from our focus groups. The first is from one of our women's groups in Togo, and it addresses this idea of marital discord and how involving men in decision-making can actually have negative impacts in some ways in which the man may actually sabotage the woman's ability to take the child for care. So when we think about that decision-making level of men as partners, oftentimes we should really be thinking about how to appropriately support engagement of both women and men for more joint decision-making, when traditionally it may be the man as the head of the household who is the primary decision-maker for vaccine uptake. And we have a second quote from one of our men's groups that says, it really depends on household harmony. A disagreement in the home can affect the children, all the while forgetting that it's a child life that is at stake. Next. Our stakeholders also mentioned opportunities that exist at each of these levels, and many of them directly respond to the challenges that were mentioned before. Our stakeholders recommended developing policies at various levels of the health system to facilitate men's engagement and orienting key stakeholders at these levels on the gender barriers to immunization and principles of gender transformative programming. And our stakeholders in Pakistan particularly mentioned including other sectors such as education and religious affairs. At the health systems level, we can think about provider behavior change interventions, formal training, and also values clarification activities, as well as other supply side interventions to create a welcoming environment. And this may include something as basic as extending service hours. And our colleagues in Pakistan mentioned that they have a very successful program now, which extends service hours beyond the traditional working hours of men, which has supported men to be able to accompany their partners to health services. You can see the various opportunities at other levels of the health system, but I won't go into them in great detail as I need to respect the time with my other presenters, and you'll see them in the slides after. Next. Our second question looked at effective and promising men's engagement interventions, and this was primarily responded to by the literature review. 20 peer-reviewed studies and additional 8 studies from the Great literature were examined, and at all levels of the socio-ecological model. And we found that these studies generally measured results in terms of child health outcomes, as well as father's behavior or knowledge outcomes. And so at the political level, we found programs that advocated with leaders to include change policies on men's engagement, and those demonstrated positive outcomes with regard to father's behavior and knowledge. At the community level, we found 2 different types of categories of interventions. The first nurtured positive community norms, so conducting sensitizations, community education to support men's involvement, and that did show positive child health outcomes. We also found programs that engaged both health and non-health leaders at the community level to promote men's involvement, and those saw positive results in both child health and father's behavior and knowledge. Next. At the interpersonal level, again, we saw 2 different types of interventions. The first was strategies for fostering couples communication through couples counseling, couples discussion groups, in which both parts of the couple were involved, either together or separately, which saw positive results in child health. We also saw couples education, which differed slightly from couples counseling, but again, engaged both members of the couple, where we saw results in child health and father's behavior. And then finally, there are various types of individual interventions in which the man was engaged, but his partner was not engaged. So that was through individual communication, either one-on-one meetings, SMS messaging, or group communication, such as men's groups or multimedia. And then also practical training, where men were brought together to actually be given child caregiving skills. Next. And it's important to note that the literature review searched child health and also immunization, but in fact, the majority of the studies focused uniquely on child health. We only found 1 study, which was in this category of practical training, which had a secondary immunization outcome. And in that study, they were looking at the benefits of training fathers on kangaroo care, which is putting a child close to your body shortly after birth. And there they found that men who were trained in kangaroo care had a larger likelihood to bring their children to immunization services compared to the control. Next. Our third question looked at effective and promising gender transformative interventions, where men were engaged, but with the goal of actually transforming gender norms. So half of our studies, 10 out of 20, that demonstrated positive child health or father's behavior outcomes did have some sort of gender transformative component. However, only 2 studies actually measured that gender transformative component. So while our interventions acknowledged that to have positive child health outcomes, there needed to be some shifting in gender norms, they didn't generally measure them. So here are the 2 studies that did actually measure both outcomes and gender transformative outcomes. The first is a community intervention in Bangladesh with 2 different types of community activities. And they found, in terms of health outcomes, a positive initiation, an increase in breastfeeding with 1 hour of birth, and an increased colostrum feeding. And they also found an increase in joint decision-making about postnatal care. Next. Our second study that did measure both health and gender transformative outcomes was an interpersonal intervention where men and women were engaged in co-parenting sessions. And they found positive improvements in child development, as well as improved joint decision-making. They found that father's interpersonal support to the mother was associated with improved child development, as well as that shared decision-making was positively associated with child development. Next. In addition to the studies examined in the literature review, we also asked our experts for any examples from the great literature. And they provided these 6 examples of programs which may not have been evaluated through peer-reviewed studies, but did have some other type of evaluation, which demonstrated positive results with regard to child health, and in all but the last case, also gender transformative outcomes. You can see when the presentation is shared, there are links to all of these activities, so you can take a deeper look at these interventions. And one of them, Safal Shuruaat, will actually be presented in the next by our next presenter. Next. So we'll just spotlight one intervention that demonstrated positive improvements in health as well as gender transformative outcomes. This project is called Bande Barejo. It was a program developed by Equimundo, And you can see the intervention. It's an interpersonal intervention, which included discussion groups for men, as well as discussion groups for men and their partners. And topics not only included health information, but dialogue on gender and power, communication, decision-making, and healthy relationships, etc.
Elizabeth?
You can see positive outcomes. Yes.
Sorry, can you slow down a little bit
Yes,
for the
of course.
interpretation? Thank you.
And you can see outcomes with regard to health, including positive ANC attendance, positive FP use, and a decrease in physical punishment of children. The gender transformative results included a decrease in intimate partner violence, an increase in support from partners during pregnancy, an increase in men's participation in childcare, a decrease in men's dominance, and an increase in men's accompaniment to ANC. Next. As part of this lit review, we also looked at measurement and asked our experts about what we should be measuring. In this case, we actually got more questions than answers, as the process of measuring men's engagement and gender transformative outcomes in immunization is quite nascent. So really, our experts wanted to ensure that we really knew what we should be measuring, and also that whatever our measurements were, we had to ensure that they could be scaled and sustained, and not just be conducted in the course of studies or one-off measures. Next. And so we did collect sample indicators, many of which do exist from other programs or other studies, such as demographic and health surveys, which currently measure different dimensions of men's engagement in immunization and child health. These aren't being used in a systematic way, and this list is not a comprehensive recommendation about which indicators we should be using, but they're simply examples that these kinds of indicators already do exist, have been tested, and can be integrated into child health and immunization programming to measure impacts related to men's engagement and linking those impacts to child health and immunization outcomes. And when we begin to design our interventions in Togo and Pakistan, we will be integrating some of these types of measures. And we should also be thinking about process indicators to really measure changes along the way to getting our intended results. So such as changes in men's knowledge and changes in satisfaction of men as clients. Next. And so to conclude, all of our stakeholders acknowledge that men play an important role in immunization uptake as primary household decision makers. We do know from other health areas that men's engagement can improve both health outcomes and demonstrate gender transformative outcomes. From our literature review and expert interviews, we found that most effective men's engagement interventions include an interpersonal component, engaging men and women together and separately, as well as community-based interventions to really begin to shift gender norms at a larger level. And it should be noted that we did have two promising interventions that were only focused at the individual level, so only engaging men and not their partners. But it's important to note that these interventions engage men as partners or individuals thinking about how they should act as partners and also as agents of change for the larger community. And when we think about engaging men as agents of change, we can also think about how that process can address supply side issues around men's comfort with the health system by engaging men as community health workers or in other ways to strengthen support within the health system. Thank you.
Thank you, Elizabeth. And this is a very good transition because I'm happy to illustrate your findings with a specific program from Safal Shuruaat in India. So my name is Alia Poonawala. I am a senior manager in the resource mobilization team at Gavi, and I'm joined today as a co-presenter by Archana, who is part of Group M, who implemented the project in India. So it's my pleasure to present today the project that was a joint project between Unilever, Lifebuoy, Social Mission Team, and Gavi. The insight being that India, as you know, loses a child every 2 minutes to diarrhea or pneumonia, yet simple interventions such as hand washing and immunization can help reverse this trend. Next. Gavi partnered with Unilever and their leading soap brand, Lifebuoy, to help tackle the issue and reduce the incidence of these preventable diseases. A traditional approach would have been to put women at the center, with a program that is by women, delivered by women health workers for women who are the primary caregivers. So reaching out to them, increasing their knowledge and capacity would directly impact the well-being of their children. And that has been proven across multiple sectors, not just in child health or immunization, but also in nutrition, social protection programs. Yet male are often the invisible gatekeepers, as has just been described by Elizabeth, and they are ultimately the decision makers. So to be truly gender responsive, we needed to unpack a little bit more how fathers were seeing their role in child health and in immunization and hand washing as well, which is a at-home daily habit. So across these multiple behaviors, we wanted to understand how fathers saw their role and how they wanted to be perceived as well. So we looked at addressing some of the gendered barriers that we identified through the formative research. Next. So some of the gender-related barriers, there are many, and I'm only going to illustrate a couple here that were truly instrumental in shaping a gender-responsive program. One was the misinformation, or rather the diversity in where information comes from. Mothers get their information from health workers, midwives, but also from their in-laws and their peers, whereas fathers were getting other sources of information, namely their social circles. And that was the big influencers and social media as well. So the fact they were getting different sources of information was not allowing them to have the same level of knowledge and understanding or awareness of some of the important health behaviors to adopt. The second is the financial component. The financial planning lies mainly with the father, who's the breadwinner and the provider for the family. So there was no or little autonomy from the mothers in this respect. And as has been put in the Q&A, there's also a lack of transparency between the real cost of immunization or going to the health post, which is sometimes not fully transparent and not fully disclosed in the home. The fact that parents are not exposed to the same knowledge limits the father's engagements, because this is a very much a female-dominated sector, whether it's by women, for women. Child health is a female domain. And so the fact they have different sources of information, different levels of understanding, actually limits the interspousal communication. And that was the focus of our entire campaign, was to promote the need for interspousal communication and co-parenting, and seeing themselves as agents of change and agents of decision at same levels. So there was little common decision-making linked to the misinformation or the lack of information or diversity of information sources, which was limiting interspousal communication. That was a true barrier to immunization. Next. So we wanted to unpack a little bit more on the father's role and the father's perception of their own role in child health and immunization. And so we used a known methodology for in behavior change, which is human-centered design, and co-designed solutions with fathers. So the fathers themselves were seeing themselves as the providers, and what their goal in parenting is they want a well-educated child who will be successful later. Whereas mothers were seen as the caregivers, the short-term, meeting the short-term needs of the child, feeding the child and keeping him healthy. So while both parents recognize a universal aspiration of a successful child, there were differences between the long-term aspirations of success and the short-term needs of a healthy child to yield to better education and long-term changing the family status and uplifting the family in the longer term. So the fact there was a different view of the parenting goals was a really interesting one, and one that we basically co-designed with the fathers, a way to go from being merely a provider to being a protector and shielding the family from disease. And that was the umbrella campaign messaging that came from this workshop. The second is, if you don't shield or don't have prevention, you lose money. You have to miss a day of work to bring your child to the health post, and you have to pay the fees of the clinic. So we've reformulated based on an insight on the financial aspect of prevention, that basically prevention of disease means saving money. And so you'll see some of the assets that were used, the coins that were used, for example, to drive that message at home. And finally, as part of prototyping and iteration through the pilot phase and then the scale up, which allowed us to refine some of the communication assets, the fathers identified cues on easy to do actions, which we then monitored and were able to then show some impact on various father-specific roles that we had crafted in the design of the project. I'll hand over now to Archana to describe the program framework and the various interventions. Over.
Thank you, Alia. So now, taking forward from where Alia left, so the core insight on which we built this program was that every parent wants their child to be successful and to lead a better life and than a life that they had led. So all parents want their children to have a better life. And the vision of the program was to persuade young parents, both mothers and fathers, to adopt those behaviors which would ensure proper growth and development of the infant. And hence the project focused on behaviors for the parents, of which we had built immunization and washing hands with soap as key actions for protection from germs and infections. And along with the focus on infection prevention, the project also talked about nutrition for children. It also talked about enrichment activities with children for their holistic development. And the role of father was laid out in each of these activities. And along with this, there was also emphasis on inter-spousal communication. Mothers and fathers were asked to communicate and plan about child's health, about their well-being, about the development goals for the child. So all of these things were inbuilt into the program. And the communication positioning, generally all the health programs talk about the survival of the child. What we did was we changed the communication positioning of the project, and we changed it from survival to success. And we said that it was all about successful parenting to have a successful child. Next, please. So I'll now talk about some of the gender sensitive information and tools that were used in the program. So as I mentioned, we had created a successful parenting platform to highlight the importance of interspousal communication, to emphasize on the need for planning together for child's future, and to have shared responsibility between mother and fathers. We also help fathers to see themselves as hero or protector, which Alia talked about, of the family, and not merely as a provider for the family. Then we used various tools and collaterals such as show cards, videos, games, demonstrations, habit formation tools, etc., for raising awareness, for addressing barriers, and for reminding and for nudging purposes. The other very interesting thing that we use in the program was the use of digital media to address largely the time-related constraints and to reach out to large number of audience through engaging edutainment content. Uh, Next, please. And the program also engaged a male and a female facilitator duo who worked together to reach out to the parents and conduct meetings and sessions with them. Perhaps in India, it was for the first time that a team of male and female behavior change agents who were both equally equipped and also shared equal responsibility worked as a team in these deep rural areas. So this actually helped the target audience to easily relate and to connect with them when they discussed about issues around shared parenting and other behaviors, especially those related to gender roles and responsibilities. Also, the engagement of male and female duo was a powerful tool in promoting gender equality. By working together and challenging traditional gender roles and stereotypes, they were able to set an example as role models. And this supported towards creating a positive change in the society. Next, please. So during the program implementation, we also realized that most of the times the men would hesitate in being part of the group meetings along with women, largely due to the existing traditional norms. So we started having separate sessions exclusively with men. We also started having sessions late in the evening, a time where generally men would come back from work. Also, the content was specially curated to match their interests and concerns. We used digital medium to reach out to men. We used to have voice calls. We had WhatsApp bot. We used to have the facility of teleconferencing through phones, and through all of these mediums we talked about both these behaviors that we wanted to influence, which was largely immunization and hand washing with soap. Next, please. Building on from the learnings and insights from the HCD that was conducted, the program also introduced some specially designed communication tools and activities to engage fathers. For example, we had developed a digital based game, and we used to have a team activity where this game used to be played between two groups, and fathers, being digitally savvy and more exposed, were quickly interested in this game. And it was also learned from SCT that equating financial benefits of good health would generate interest in men. So that angle was also used in the digital game. The game helped them to realize how good and bad parenting behaviors could actually have an impact on financial outcomes for the family. The game helped to foster mental accounting, and establish the key message to get them more interested in childcare activities to support the mother. We had also we also had a game of quiz to largely foster healthy competition among the participants, and by showcasing responsible fatherhood behaviors in the quiz questions and answers, the game served as a platform for role modeling and for inspiration. Participants were then encouraged to emulate positive parenting practices in their own lives. Next, please. A third-party research was conducted of the entire intervention, and we had some very amazing results from this third party. We realized that the understanding around co-parenting had increased in the intervention area. There was a 45% increase in the belief that childcare should be discussed between both parents and not just should fall on the mother's shoulders. And then there was a decrease of nearly 14% in negative attitude from parents who believe that fathers should only take care of child when the mother is too busy. Next, please. Similarly, there was significant increase in attitude and recognition of interspousal communication and timely immunization as critical aspects of parenting was observed in the intervention area. Like talking to a spouse regarding childcare and child's future increased by around 27%, and ensuring the child's timely immunization increased by almost 26%. Next, please. At an overall level, we saw increase in knowledge, attitude, and behaviors, both for immunization, hand washing with soap, as well as parenting behaviors. So the incidence of hand washing with soap post-defecation increased 5 times. Hand washing by mothers before breastfeeding increased 6 times. And there was significant increase was observed in uptake of key vaccines like pentavalent and rotavirus. And there was significant improvement in understanding of key parenting behaviors like need to bond with child and ensuring adequate nutrition. Next, please. Yeah, so now I'll hand over to Alia to sum up the presentation.
I'll just share 1 minute closing remark. Thank you, Archana. So the program impact showed like 5-fold increase in hand washing with soap at critical occasions and almost 30-point increase in uptake of rotavirus and measles vaccines. There was a father-specific route, but there was also a lot of other IPCs and a multiple, this was a big behavior change campaign. We took a gender lens today to try to see how this type of intervention could shift gender norms and we're started to measure them. We have now gotten really strong results with more than 3.7, actually now 3.8 million people reached in UP. And this has been an award-winning campaign in Uttar Pradesh with, for example, a lot of credentialing and endorsement also from the government. So the additional secretary from the Ministry of Health and Family Welfare, the government of India, particularly highlighted the fact that this had a focus on fathers and was giving responsibility to fathers to play a leading role in child health and immunization. And so this has been really a big highlight and a big win also for other states in India to adopt the campaign. So now we are replicating the project in Indonesia, where we're shaping and hopefully taking all the action list items that have been shared in order to share new results on father engagement in immunization. Thank you very much.
Thank you so much. And I think we're going to try to share a short video on this. So Alex, if I can hand over to you, do I need to stop sharing? And then you can start and we'll see if we can make this work.
Give me a second. Up.
And that's very exciting. In the meantime, that's very exciting about the Indonesia follow-up project. So we'll have to invite you all back to share the outcomes of that in the future once that's been implemented, to share those learnings in a different setting.
India has made a significant progress in reducing deaths amongst children under 5, but pneumonia and diarrhea remain the top 2 contributors to preventable deaths. Immunization and hand washing with soap are 2 most cost-effective child survival interventions against pneumonia and diarrhea. Program Safal Shuruaat, or Successful Beginning, co-sponsored by Gavi the Vaccine Alliance and Hindustan Unilever's Lifebuoy, aims to drive behavior change amongst parents of 0 to 2-year-old children on immunization and hand washing with soap at key occasions. The program encourages young parents to adopt these behaviors to ensure age-appropriate growth and development such that the child is not merely surviving but thriving. The program integrates nutrition and early childhood development in addition to immunization and hand washing with soap for holistic intervention. The program is built on intensive interpersonal communication done by male-female communicators who take the parents through a journey of learning and behavioral modeling using a mix of technology-enabled IPC sessions. Safal Shuruaat has made significant changes in knowledge, attitudes and practices of the target groups. The compliance for 3 priority vaccines showed significant growth. Hand washing with soap post-defecation grew by 57%. The incidence of hand washing with soap by their mothers before breastfeeding a child increased 6 times.
That was fantastic. Thank you for sharing that. I'm just going to share my screen just so we have the links up for everybody at the very last point, but we do still have a few minutes for questions and answers, which is great. I see that there has been a little bit of engagement in the Q&A box so far. So I do encourage you to go and type your answer there, or sorry, your questions there. And we still have a little bit of time to direct them towards our speakers. Maybe while we're waiting for additional questions, I'll invite Elizabeth actually. She responded to this question from Jean-Pierre in the chat already, question sort of comment, but I think it's a really interesting one to raise, and it also really highlights the importance of actually engaging with the specific communities and finding out really the root causes of the problems and tailoring interventions appropriately. But Elizabeth, I'll hand it to you to elaborate a little bit since we have some time.
Thanks very much. So yes, the question was that we sometimes see that women themselves are more hesitant to engage their partners because this, when they do it themselves, this allows them to be a bit dishonest about the amount of money that's needed, either for the services or the transport, so then they can get money from their partners and then take the rest as they come back. And actually, we see not necessarily a question of dishonesty, but this comes to a larger point that when we're thinking about men's engagement, we also need to think about how women want men to be engaged, right? We know that in many cases, the health center can be a safe space for women. It can allow women to come together, socialize, create their social support network. It can also be a place where a woman can disclose violence with a health provider. There are many reasons why a woman may not want her partner to come with her to health services. So we should really be thinking broadly about what we mean by men's engagement, and also thinking about during this co-creation process, not just asking men how they want to be engaged, but asking their partners how they would like men to be engaged as well. And my response in the chat was specifically looking at this issue of dishonesty around finances. We heard this issue from our colleagues in Togo, from our caregivers in Togo, and they mentioned that in many cases, women don't have their own access to finances. So this creates this need to get money wherever they can. And many recommended that as we're thinking about this idea of joint decision-making and how we shouldn't be reinforcing men's power to be the main decision makers, but also creating an environment where women can have an active role in that decision making. Part of that involves increasing women's financial autonomy and thinking about how we can integrate income generating activities for women as part of this process of changing norms around joint decision making.
Sorry, I'm muted. Thank you so much, Elizabeth. Thank you for that, that elaboration. I see that there's a hand raised, but I'm not sure that we have the ability to unmute. So maybe if I can just invite you to please put your comment into the chat box or into the question and answer box, and we can address it that way. Just while we're waiting, I see that Abdu had a really interesting question early on about whether a program can be gender sensitive, specific, and transformative all at the same time. And Shirin already kindly responded to that one a little bit, but we do have a little bit of time to elaborate. So yes, indeed. I mean, of course, there are different elements of a program and they can be individually falling on different points of the scale. And Abdu asked for a couple of examples. And so I do want to direct everybody to the Why Gender Matters guide, because there are a lot of good examples in there that can help understand a little bit more about the gender responsive scale and what is a gender sensitive versus a gender transformative intervention. But maybe just linking it up to the topic at hand today. So, you know, gender specific would be you know, having communication materials that acknowledge that men and women receive information differently, and therefore target the populations in a different way so that the messages are reaching both men and women. Whereas the transformative aspect of that would be more along the lines of the examples that we heard about today, where the messaging actually engages and challenges some of the underlying social and cultural norms that are harmful or unhelpful to advancing the goals of the immunization program or our health-seeking behavior in general, and actually move to try to change those behaviors. So it is definitely not something that can happen overnight. And I noticed that somebody did put in the chat that a lot of this work actually really did involve engaging and addressing sort of religious and socio-cultural traditions. And it is true, behavior change, as we all know, for all of us who work in the immunization space, any sort of behavior change intervention is not an easy thing. It definitely takes a lot of work, and it's unpacking a lot of different layers. So, so indeed, we're to the woman who had her hand raised. Were you able to include your comment in the chat? I don't see anything. If anyone else has any questions, please, I do invite you to write them, because we do still have a few more minutes. If not, then maybe it just means that the presentations were extremely clear and detailed. As always, the materials will be shared after the call within the coming days, along with the recording of this webinar. So do feel free to refer back or share it on to your colleagues. And all the materials are available at this TechNet link right here on the screen. And just back to what I mentioned at the beginning of the call, for those who joined late, we are going to be sending out a very short survey to seek your feedback on this webinar series, but also some input on what you would like to see at a subsequent webinar series if we host a part 2 of this in the fall this year. We do still have a few more examples of gender transformative interventions for the immunization program that are covered in the guide that we weren't able to do a deep dive into on this particular short 5-part series. So there's still lots of room for additional topics, but we want to hear from you what you liked, what you would want us to repeat, and what you would like us to include in another webinar series. So please take the time to fill that out when you receive it. With that, I just want to thank our TechNet hosts and interpreter as usual, and of course, Michaela Manna for all of her work coordinating this webinar series. I can hand it over to you, Alex, for any final closing, but otherwise I think we can wrap it up.
Thank you very much, Stephanie. I think you said it all. So I would like to thank everyone who joined us today and the last sessions. You're going to receive an email in the following hour from me, and the mail with the links to the material in the coming days. I wish everyone a beautiful rest of the day, and well, hope to see you again soon for another webinar session. Thank you all, and have a very nice rest of the day. Bye.